afternoon, everyone. I'm going to start because actually I'm 4 minutes behind. The timer started when I wasn't paying any attention. So good afternoon. My name is Ann Peterson. I am the Director of Population and Global Health and the Sexual Assault Service at BC Women's Hospital and Health Centre here in Vancouver. I'm honored to be the moderator for this afternoon's session. And glancing out the window, I'm recognizing that I'm on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh on a rainy autumn afternoon, where the colors are still vibrant. And so I feel like there's sunshine captured in the leaves, which is part of the way I think of the fall. Am I echoing? So
they're changing your level.
Back it up a little bit or something. Better? Better? Okay, thank you. So this session, oh boy. Okay, this session is about the co-production, the co-creation of knowledge translation products on reproductive health, reproductive loss and bereavement. And in full transparency, I'm actually a member of one of these projects, but I will not be speaking as a member of that project. And that is the first one that we're going to hear from. But before we introduce the rest of the panel, I'd like to introduce and welcome Heather Stroesher, who's here in the front row. Heather is the instigator of this event this afternoon, and she's joining us from Vancouver Island, where she is the knowledge broker for the support unit on the island. And she is embedded in Island Health's research department. So thank you very much, Heather, for instigating this and for welcoming all of us to come together. We have two presenters in the room and one online. The in-room people will speak first, and then we will shift to Rana, who's not able to join us in person, and then we'll have questions after. So if you can jot your questions down and hold them till the end, that would be the most convenient. Just to put all of this in context, I'd like to remind you that estimates are that more than 15% of couples have fertility problems, and somewhere between 15 and 25% of pregnancies end in miscarriage. So although we think of loss as uncommon, it's actually surprisingly common. Stillbirth, which is the project that I'm affiliated with, is defined in Canada as the loss of a baby after 20 weeks gestation and before birth. Approximately 3,000 families, that is 1 in 200 pregnancies, experience a stillbirth annually in Canada. So again, surprisingly more common than you might think. The purpose of this session is not to raise your awareness of the nature and scale of reproductive loss, but to illustrate how some folks are responding to this situation. So this afternoon, we're going to hear from two experiences of co-production of knowledge related to products responding to addressing miscarriage and stillbirth. So first, we're going to hear from folks associated with the Hummingbird Project. First, we're going to hear from Jamie Asher. And Jamie's a co-investigator of the Hummingbird Project and brings both lived and learned experience of stillbirth to her work. She has been engaged as an advocate for people whose babies were born still since her sons James and Zachary were born still in 2010 and 2013, respectively. Jamie is passionate about developing resources to support bereaved parents and is driven to create tools for clinicians, both in hospital and community settings, to better support families through stillbirth. Her dedication to this work is best evidenced in her role as co-host for the new podcast, Stillbirth Happens, Let's Talk. Joining Jamie is Lana Sullivan, who is also a co-investigator with the Hummingbird Project and its research manager. Through her role on the Population and Global Health team, so that's our team, at BC Women's Hospital and Health Centre, Lana has partnered with clinicians to develop resources to support the hospital experience for families coming to the hospital for care and support around stillbirth. Lana is passionate about developing resources and that will support people as they navigate stillbirth in hospital and after discharge. Jamie.
Thank you, Anne. It's a pleasure to be here this afternoon. Lana and I are excited to be here today to share that our team has developed a podcast to support parents who experience stillbirth. We'll talk about the podcast and even give you a chance to listen to our trailer. Most importantly, though, we want to tell the story of how our podcast came to life, specifically the process we use to work and work together. The goal of our presentation today is to talk about co-production and how our research, including our podcast, came to life by our team with both lived and learned experience of stillbirth. The names you see in the garden on this slide are actual names of babies who were stillborn. This work is part of their legacy. Before we begin, we would also like to acknowledge that we live, work, and play with great privilege on the unceded and traditional territories of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh. We acknowledge that we are coming together virtually as well from across many traditional and unceded territories, covering all regions of British Columbia. We are honored to live on this land. The Hummingbird Project started by bereaved parents hoping to better support people who were pregnant after stillbirth. In 2017, the project set out to organize group clinical support for people who became pregnant after stillbirth. Bereaved parents taught us that they need support throughout their grief journey, not just at the time of their next pregnancy. Our Hummingbird Project team consisted mainly of a group of bereaved parents from a grassroots organization who wanted to provide support, education, and do research related to stillbirth. We had successfully completed a previous research project and hosted an international stillbirth conference where the Hummingbird Project was created from the calls to action. The project evolved between 2017 and 2019, with bereaved parents leading all aspects of the work. From our initial focus group, the information gathered indicated that it was not group clinical support during subsequent pregnancy that was needed. Everyone we spoke to was pregnant, and they all wanted to talk about their stillbirth experience, not their subsequent pregnancy. They desired accessible support in real time and bereavement care related to their stillbirth experience. During a brainstorming session about how to shift our project focus to support those who experience stillbirth, the idea of producing a podcast came to be. We developed and recorded a 4-episode pilot series, having reached out to international stillbirth and bereavement colleagues to have as our experts on the episodes. We knew we needed a platform to share our podcast series, and in 2019 approached the team at BC Women's Hospital and Health Centre in hopes they could be housed within the BC Women's website. Our project timeline is highlighted by the 2 colors. The yellow line is the time we spent as our grassroots team planning, researching, and creating our pilot episodes that we brought to the team at BC Women's. The blue line shows where the Hummingbird Project and BC Women's came together. Since 2019, we have been working to bring lived and learned experiences of stillbirth together. The Hummingbird Project team brought both lived and learned experiences of stillbirth. This meant we understood perspectives of bereaved parents and had foundational knowledge of tools to best support families after stillbirth. We believed podcasts would provide bereaved parents with support wherever they were. The BC Women's team brought learned experiences of stillbirth and administrative skills. This meant an evaluation of the pilot podcasts identified very few Canadian podcasts on stillbirth existed, and that indeed a podcast was an innovative approach to provide support. They brought experience with project and financial management, university ethics procedures, and other administrative details like scheduling, agenda setting, and minute taking. They brought skills to reach out to clinicians. By combining our skills and experiences, we decided it was important to go back to bereaved parents to ask more questions around podcasts as support.
So as we decided to head back into the field to talk with bereaved parents about podcasts, we knew we had to do things differently. From our BC Women's team, our experience working with patient partners had always started with us reaching out. And given the Hummingbird Project had come to us with 2 years of experience doing research themselves, we knew we had to do things a little differently. Co-production acknowledges that people with lived experience are best placed to advise on what support and services will make a positive difference in their lives. When it is done well, co-production helps ground discussions in reality and maintains a person-centered perspective. The model you see is the value system of co-production. For co-production to work, these values and behaviors become norm. For our team, ownership and understanding came from meeting regularly, prioritizing in-person as well as virtual meetings, and taking time to identify our own positionality within the research. We acknowledge our own degrees of privilege and understand that from our respective social positions. In acknowledging positionality, we also acknowledge intersecting social locations and complex power dynamics. A culture of openness and honesty is fostered through sharing and reflecting. To start each meeting, we are intentional about sharing parts of our day or of our week. We don't edit the difficult parts. We share them candidly. We recognized from the beginning that when we were first meeting with our bereaved parent partners or people with lived experience, that our first interactions with them often came by them sharing one of the most intimate and traumatic experiences of their lifetime, which was their stillbirth experiences. So how could we not in turn share a piece and become vulnerable as part of the team? So it was important to not only let those with lived experience of stillbirth be the ones who were vulnerable. We needed to meet them where they were. Shared power and decision-making is essential to our approach. Each decision is discussed at length in our meetings until we reach consensus. We must remain vigilant about maintaining a horizontal decision-making structure. Communicating in plain English is perhaps the easiest part of the model, yet in practice, it actually can be challenging. Ensuring equal understanding within our teams means we must help each other navigate circles, taking turns leading. When we are in academic environments versus circles of bereaved parents, we take turns accordingly and appropriately. Every interaction within our team is focused on creating a culture where every member of the group is valued and respected. So I'm really aware after the last panel session that we were present at, that I'm definitely preaching to the converted. So as I talk about all of these things, in some areas, I think that some of the things that I'm talking about are innovative and maybe even really cool. And that amongst everybody here, we're kind of past that. But I still think that telling the story and writing about it and talking about it is important. So we're here in that spirit today. So co-production, of course, as many of you already know, is not as easy as it sounds. It can be actually really challenging. We must be vigilant, and I'm speaking more about those of us on the team that are bringing learned experience of stillbirth, about not slipping back into our old ways of vertical decision making. We must start meetings by sharing pieces of our life, working to build trust that we just heard the panel talk about. Friendships even, I said, but of course the panel talked about love. As soon as they said that, I thought, yeah, actually that is what it is. And reach a common ground when considering one another's perspectives. For those of us trained in university research methods, co-production as an approach is really different than what we learned about in grad school. It necessitates being personable and getting personal. It involves being vulnerable. It also means that things take longer. While some projects may have quick 30-minute meetings, our meetings may often take 90 minutes or longer. We meet in the evenings or over the weekend. We need to pause progress until everyone has the opportunity to get on the same page. We take extra steps, like training sessions on how to use Google Docs, to make sure we're all speaking the same language. We also need to be humble when we don't get things right. Again, I'm usually talking about those of us with learned experience of stillbirth, and brave when we're apologizing for mistakes on process or approach. Navigating these challenges enables us to bring our lived and learned experiences of stillbirth and research together.
Since 2020, we've spoken with over 50 bereaved parents. Team members with lived experience of stillbirth have led all interviews and focus groups, and members with learned experience of stillbirth have been silent note takers or have provided administrative support with ethics, invitations to participate, transcription, etc. We asked bereaved parents whether podcasts would be a useful support tool after stillbirth. We have shared 3 quotes from our research here. The initials you see on each quote are pseudonyms chosen by participants of our focus groups and interviews. The feedback from people who spoke with us is at the center of every decision we make in the project. People with lived experience of stillbirth and their babies guide the work. Bereaved parents taught us that stillbirth is an isolating experience and that babies should be recognized and at the center of each interaction with clinicians. We learned that stillbirth changes you forever. They also were clear that bereaved parents must advocate for themselves throughout the stillbirth journey with their babies. Bereaved parents we spoke with felt podcasts would be a useful support tool after a stillbirth experience. They shared podcasts could help with the understanding grief as a journey, navigating grief with their family, and providing support to their living and subsequent children. People we spoke with endorsed the idea of a podcast. They provided feedback on episode topics, length, style, format, and how they wanted to access the podcasts. The quote from JA on the slide encompasses what we wanted to create and shares the power of storytelling and connection. We wanted to create a resource that provides comfort and support. The original Hummingbird Project team wanted to bring stillbirth out of the shadows, reject the stigma, and talk about it. Bereaved parents we spoke with agreed and wanted stillbirth to be talked about as part of the maternity journey. The title for our podcast was clear: Stillbirth Happens, Let's Talk. The podcast is hosted by Erin Bone and myself, who are also co-investigators of the Hummingbird Project. Both Erin and I have lived experience with stillbirth. It has been important for both of us to be part of and support our stillbirth community. Over the past several years, we have both worked on various projects in honor of our stillborn babies. The Hummingbird Project enabled us to work together with the larger project team as co-investigators. When it was time to choose hosts for the podcast series, the team decided that we would step into the co-host roles. Our trust and understanding of each other set us up well to have the conversations and relate with our guests and our listeners. Erin and my lived experience of stillbirth also helped establish safety for our episode guests. Our shared understanding of our babies being born still facilitated candid conversations about stillbirth and allowed our guests to share honestly and grieve openly. Developing the podcast required expertise from all members of our team. As a group, we identified our episode topics from our data. We brainstormed potential parent and clinician guests. Lana, as project manager, worked with the podcast production company Jar Audio for technical and sound expertise. She invited our guests and worked with them to establish trust. Our team worked together with Jar Audio to write the scripts, which we reviewed from our areas of expertise, medical content expertise, lived experience, and audience appetite. We then recorded and debriefed each episode. We reviewed audio and edited the episodes for length and relevance. We then shared with our guests for their feedback. And then we had our go live date. All 5 episodes of our season 1 are live and available to listen to. The first season of the podcast was developed using the same principles of co-production. Episode themes were identified by people we talked to. As bereaved parents told us that stillbirth stories normalize their own experiences of stillbirth, each episode is a conversation with a parent guest whose baby was born still. Bereaved parents also told us they were interested in clinician perspectives about stillbirth. Each episode also features a clinician who answers questions about stillbirth. The format, length, style, and music of each episode are all informed by conversations we had with bereaved parents. Our season 1 episodes follow a story arc through the stillbirth experience, one that takes us from the moments of learning that your baby will be born still, through to the acknowledgement that stillbirth changes you forever. However, it is important to share that we were very intentional with the development of the episodes, and they have been created so that anyone can listen to the episodes in whatever order they wish. They do not need to be listened to chronologically. To give you a sense of the sound and feel of the podcast, we will play the trailer for everyone to listen.
Stillbirth can be difficult to talk about. Yet, like lots of things that are hard to talk about, stillbirth happens. I'm Erin Bone. I'm mom to 3 children, my living children Gracie and Quinn, and my daughter Ryan, who was stillborn in 2010.
I'm Jamie Asher. I am also mom to 3 children, my living daughter Marissa, my son James, who was stillborn in 2010, and my son Zach, who was stillborn in 2013. Erin and I first met at a conference we attended to learn more about and share our own stories of stillbirth. Since then, we have worked together to reduce the stigma of stillbirth and bring support to others whose babies are stillborn.
We know stillbirth is devastating, and we also know that hearing from others with shared lived experience helps as you navigate your new reality. That's why the name of this podcast is Stillbirth Happens, Let's Talk. It's brought to you by the Hummingbird Project at BC Women's Hospital and Health Centre.
We aim to support bereaved parents by bringing their experiences out in the open. We hope the voices and stories heard on this show will help others to grieve and heal.
And parents are not the only ones learning to live with the reality after stillbirth.
So whether you're a bereaved parent, a loved one, or a caregiver wanting to learn more about how stillbirth affects people and how to handle it, this podcast is for you.
And above all, Jamie and I want you to think of this as an honest, welcoming, safe audio space. A space where we can come together to learn, to grieve, and to feel connected.
Please join us whenever you can and share this podcast with anyone who needs it. Take good care of yourself and talk to you soon. We are proud of our podcast, Stillbirth Happens, Let's Talk, because the podcast was developed at every stage by parents with lived experience for parents with lived experience. We feel fortunate to have recognized early on that while it was important for us to lead the processes, we couldn't do it alone. And our success also came because of our partnership with people with learned experience of stillbirth. We encourage you to check out our podcast on any platform, or you can use the QR code to visit our landing page where you can access all of the episodes as well as resources on stillbirth and reproductive loss. If you have any questions about the podcast, feel free to reach out to Lana. Thank you.
I feel a need to pause. And I've been through every second of this work. So, thank you very much from the bottom of my heart. I'm wondering if we have a video of Rana yet available. Do you have the video for Rana? It feels strange to introduce someone we can't quite access yet. Here we are. Wonderful.
Rana, we're good for your segment.
Thank you so much.
Rana, can you hear me okay?
I can. Everyone can hear me okay also?
Fantastic. Thank you so much. There were several thumbs up in the room. I'm really grateful for the person in red in the back who keeps giving me the sign. So I'd like to welcome and introduce you to Dr. Rana Van Tel. She's a researcher and bereaved parent who lost her spirit baby to miscarriage. Rana's applied research interests include pregnancy loss, women's health, and the social determinants of health. She recently joined the board of directors for the Butterfly Run, which grew from a provincial walk run to a national nonprofit this year to support patients and families who have experienced infertility, pregnancy loss, and infant loss by creating community, raising awareness, and fundraising for support programs. Rana, over to you.
Thank you so much, everyone, for having me joining me virtually today. It's with deep gratitude that this research project on miscarriage recovery was made possible by patients and community members, and it is dedicated to the many families who have navigated pregnancy loss. Before I dive into a description of the project, I would just like to take a moment to share a lived experience and positionality statement that's related to this project. We lost our first pregnancy in December 2020 to a miscarriage. And although I received medical management for the miscarriage, I went on to have complications for over a month before I was referred for in-hospital ultrasound and later surgical management. While this is not the case with all miscarriages, ours took us down the road of secondary infertility for over a year before we were fortunate enough to begin working with a fertility clinic in the spring of 2022. And this April, we were so fortunate to be able to welcome our son, Addie, Earthside. And as grateful as I am to be the mother to Addie and to welcome him Earthside, I do also want to acknowledge that it doesn't erase or replace the previous loss. Sometimes rainbow baby narratives out there can make it sound like that. And most importantly, I just want to acknowledge all of the patients and families out there that have experienced recurrent losses and have never been able to bring one of their babies Earthside, including various patients that participated in this particular project. While it was my lived experience with miscarriage and the many women I met along the way that shared similar stories that brought me to this research area, it's the magnitude of the health issue that has me continuing to focus in this area. As Anne shared already, approximately 15 to 25% of pregnancies end in miscarriage, and more than 15,000 miscarriages are occurring annually in BC. And while this number is significant, and it is indeed, we also know this number is significantly underreported because BC's current mechanism for recording and reporting pregnancy losses only records miscarriages for people who go on to have a delivery, either live or stillbirth. It doesn't include people who have only experienced recurrent losses. And we don't have data for estimates in Canada because Canada does not have a national mechanism for reporting and recording pregnancy losses, with the exception of stillbirth. This is particularly problematic because we know that pregnancy losses can have a significant mental health impact on patients and families. This isn't always the case, but on average, mental health recovery from pregnancy loss can take 2 to 4 years. However, it can also take longer. And this recovery can be impacted by not knowing why the miscarriage occurred. I always think this is really important to point out because there's still a very prevalent narrative within BC that all miscarriages are not preventable and chromosomal abnormalities, where actually, in fact, it's more like 50 to 60%. And then there are a significant amount of other risk factors, including biological, social, and environmental causes. And I think this is important to point out because if we don't know this, then as healthcare providers, we don't know where to start looking a lot of the time. So this leads us to the current problem in BC around pregnancy loss, and that is without targeted research and improved pregnancy loss care, patients and their partners will continue to struggle with under-resourced support services, face high rates of pregnancy loss, and endure the devastating mental health challenges that may follow this loss. This particular project took a patient-oriented and community-engaged hybrid approach. It involved policy analysis of prenatal care guidelines at the provincial and national level, as well as policy analysis on bereavement leave legislation, interviews with 27 people with lived experience of miscarriage, and 4 people also opted to participate in a discovery action dialogue, which is like a small group or focus group with a solution-focused orientation. I won't spend too much time on this slide because there's ones that I find more important that I want to spend more time with you on, but there was participation across all health authorities in BC. Participation included urban, rural, and remote geographical settings. All patients reported between 1 and 4 miscarriages, and then 27% also experienced other types of pregnancy and baby loss. I would like to take just a moment here while we can reflect in silence, if that's okay with all of you, to read a few of these quotes on our own. These are just a few of the many stories that were shared from the patients that participated in this project. These stories and the many others that were shared by the patients resulted in 4 core themes and various sub-themes. I'm sure these themes aren't a surprise to any of you. For the purpose of our time together today, which I know is short, I'd like to focus in on 3 of the key patient experience themes that I think that are most relevant to a healthcare provider audience that patients would want them to know. First and foremost, the majority of patients commonly reported a lack of or complete absence of follow-up care following miscarriage. This included things like being dropped immediately after the miscarriage and not even having one follow-up visit with their healthcare provider. It also included examples like not being provided information on what to expect next or incorrect information, and then 2 other kind of prevalent sub-themes were lack of mental health screening and referrals, as well as ultrasound referral to check for complications. Another key patient experience is language. So various patients talked about how terminology such as spontaneous or missed abortion, products of conception, and to confirm one's miscarriage did not resonate with them. More commonly used by patients is to refer to pregnancy loss or baby loss, like we've talked about in this particular presentation, as well as Jamie and Lana's. One patient in particular pointed this out in such an eloquent way, where she said, "I just wish they would have asked what I wanted it to be referred to." And for her and her husband, they wanted their loss to be referred to as a baby. And lastly, for this finding here is around ceremony. So people who have earlier losses are rarely offered cremation or other ceremonial services by their healthcare providers, which is an area that can certainly be addressed within the healthcare system. And so the majority of people sought artifacts to remember their babies. Switching from patient experiences to the findings of the prenatal care guidelines, again, I'll just share 3 of the key findings for the purpose of timing today. First, I'd like to share that national and provincial guidelines are currently missing many of the biological, social, and environmental risk factors of miscarriage. This is particularly tricky because within the last several years, there has been significant research done, particularly out of the UK and Tommy's National Centre for Miscarriage, research that is showing both biological factors and prevention that can support people to reduce the number of miscarriages that are occurring. That does not mean that every miscarriage can be prevented, but there are various known factors such as structural abnormalities of the uterus, various blood conditions, various hormone conditions, and so on, that can actually receive testing and preventative care. And so if this information isn't included in our provincial and national guidelines, it makes it really difficult for healthcare providers to know where to start looking. Secondly, BC used to have a maternity care pathway that included information on talking to patients about early pregnancy loss so that they were aware that this could happen, as well as screening and providing additional care for high-risk patients. In the iteration that replaced the maternity care pathway, this information is no longer included, and so unfortunately this is a current gap. And so not everybody is receiving this information or care within the start of their maternity journey. And then lastly, while BC has a prenatal care guideline for stillbirth, which includes an evaluation and care checklist, a similar document does not exist for miscarriage and other early losses. And then lastly, the last policy analysis was on the bereavement leave legislation. As you can see, the majority of bereavement leave across Canada is unpaid, and that is for all types of losses, whether it's a child, a spouse, or someone else near to you. And the majority does not include pregnancy loss language. And so what this means is, first, that we don't have equitable access to bereavement leave. That means people who rely on a paycheck are not able to take the time off to grieve a loved one in the same way as somebody who does have the financial means to take time off. And that is really problematic for helping people have that time to grieve. And then secondly, by not having pregnancy loss in the majority of bereavement leave legislation in Canada, it leaves employers and employees to have to figure out on their own if bereavement leave covers them for that time off. So another area that we can definitely improve both as a province and across Canada. These research findings from these different sources were then triangulated to create a policy brief. Most importantly, this policy brief was shared with the patients who participated in the project for member checking and feedback loops to make sure that it accurately captured the ideas that they had, as well as the stories that they shared. I also want to acknowledge that not all teams come with graphic design skills, and so we had the honor of working with a freelance graphic designer to support this product. And last but not least, the policy brief is in its final steps of being finalized, and then it will be shared with health authorities and government agencies. It's an extensive document in the sense that we include recommendations per agency and authority to help them kind of pick out what's relevant to them. But 6 key focus areas across the policy brief are to improve prenatal care guidelines for early pregnancy loss, equitable bereavement leave for pregnancy loss, dependable follow-up and mental health services, earlier testing for high-risk patients and recurrent losses, national monitoring and reporting on pregnancy loss, and advanced research on risk factors and prevention. And then I just want to close before we head into the question and answer period on some key takeaways for those who are considering to engage in patient-oriented research, either as a patient partner or somebody who is involved in the research design team. First and foremost, embracing a flexible mindset, and this is anywhere from the research design to the materials, and most importantly, the timeline. For example, we extended the timeline for interviews on this project quite a few times because there were various people who wanted to participate, but current situations in their life wouldn't enable them to participate within the current time frame. An example was we had one mother who was pregnant in her 3rd trimester and really wanting to participate, but because she lost her previous pregnancy in the 2nd trimester, it was important to her to first bring her baby home before she wanted to participate in an interview. And completely understandably, we made that possible by extending the timeline of the project. When we take trauma-informed approaches such as this, research can be therapeutic. A few other examples that I'd like to share is instead of sharing mental health resources after the interview, which is still quite common, we chose to share those before so that people could choose to access those ahead of interviews if they wished. And the interview questions were also shared ahead so that there weren't any surprises and that nobody felt caught off guard by what would be asked. Lastly, I have a colleague who also often hires counselors on her projects with lived experience, and this is a great way to also support people in a trauma-informed approach on sensitive projects. And then as a final note, we can and should be doing better. That is intentionally broad. We can and should be doing better in terms of pregnancy loss care and prevention in BC and across Canada. And I think a really important place where we can start in the patient-oriented research space is to make sure that we're compensating patient partners fairly. It's very common to see large projects with a lot of funding and very poorly paid participation for patient partners. So I think that we can make a very important equitable change in that space. And then, as Lana and Jamie were talking about power dynamics, also ensuring that there's a better balance between patient partners and the rest of the research team members. If the majority are healthcare providers and only a couple of patient partners, that dynamic can be quite overwhelming. So I will pause there, and I think we will then open up for questions. Thank you everyone so much for having me.
Thank you very much, Rana. We have 15 minutes for questions, and we have at least one that's come in online, and Heather has offered to share that with you. And then perhaps we can open it up to the conversation in this room. So.
Thank you so much to the presenters. That was really valuable, and I'm so grateful to be in the room with this presentation and session. So the question that came in, there's two actually online, but we'll start with the first one. What unique considerations and practices are needed to respectfully, meaningfully, and productively engage with people who have lived experience with pregnancy loss, bereavement, and other sensitive experiences? Do you want to go ahead, Rana?
Sure. I think that maybe kind of where I left off can dovetail into this a little bit. As a group, when we first met, we talked about how unfortunately a lot of projects can take like a tokenistic approach to engaging partners. So I think the kind of key place to start out is really asking yourself the hard question: are you doing that? Are you just engaging somebody to have that patient partner and to say that, or are you genuinely wanting to create a safe and fair and equitable space for that patient partner? And as I touched on briefly, one key way to make sure that you're doing that is making sure that they're compensated fairly and providing equal or at least balanced numbers between healthcare providers on the team and patient partners. And I'll pause there and see if Jamie and Lana have anything they'd like to add.
So this is, I feel like Amy from CIHR, if I have that name right, talked a little bit about the progress that we are making and the work we have to do. And I feel like that's how I feel in response to this question. So what we have done is we have been really intentional about having, well, I mean, for this particular project that we presented on today, it was different because we didn't reach out to patient partners, they came to us. So it really flips the script in terms of what we're talking about. But generally, with a lot of the work that we're doing with people with lived experience, we are reaching out, and there's somewhat of an advantage because we work very closely with the clinicians and who support people when they come into the hospital for support, and they have relationships that extend far beyond discharge or that in-hospital experience. And so they develop trust and relationships with people with lived experience, and for different projects, and we've worked with them for quite some time. They do often present opportunities to become involved in the work that we're doing, and we often will get people that way. So I think that we've been really fortunate to be able to engage people with lived experience, and people come to us quite willingly. We also work closely with organizations like the Butterfly Run that use their network to post advertisements to get involved in the work that we do, and we get people with lived experience that way. So that's the progress. The work is a lot of what came up in the panel, which means that we're putting invitations out for people to respond to, and not necessarily volunteer their time, because we really work hard at putting portions of our budget aside to pay our patient partners and to honor their time in as many ways as we can. But it's the people who volunteer. So we talked about the wow or the cow or the bow. So who's volunteering? And we've got work to do there. We need to, in some ways, reach out in a more targeted ways to make sure that we're hearing from everyone about their experiences. I'm not sure that we can confidently say that we've done that. We're thinking about it. We're challenged by it. We know it needs to happen. We haven't got the solution. Yeah. Oh, hold on, before you do that. Yeah.
I was just gonna say, I really, really appreciate resources like this, so thank you so much for putting the time and effort into making them, because these situations and the management depend so much on care provider, your facility, and the available resources, as well as maybe the health authority that you live in. And so just drawing on that previous question about the uniqueness of each situation, and one of the challenges being with co-production, making sure that we're hearing voices from rural communities as well as different diverse communities. I was just wondering, in terms of the episode, What Happens at the Hospital, was there any sort of research or thought process into kind of the different rural situations that may come into play and the differences that come with that situation?
So, Jude, did you plant that question? Okay, so I am a geographer. And so what the heck is a geographer doing working in health research? Sometimes I question that, except that I just have this really lucky job that I happen to get paid to do stuff that I love. But I had the privilege out of grad school to work with incredible teams and travel the province. I was educated at the University of Northern British Columbia and spent most of my undergrad and graduate time living and working with people in rural and northern communities in British Columbia. And I came down to Vancouver and joined with Jude Cornelson and many colleagues and continued maternity care research, listening and talking with people who live maternity care every day in rural and remote communities. So this is something that is really close to my heart, and I'm always the squeaky wheel on the team to say, What about the people who don't live in Vancouver? BC Women's Hospital is a provincial organization. We need to deliver service and support people in all four corners of the province. I'm saying that constantly, mostly to an eye roll crowd, but most of the time there's people saying, right, we have to do things differently. So for the work that we did, and Rana beautifully showed the diverse number of people that she talked to in all corners of the province as well. But we were able to use Zoom to engage people in our workshops. We try and get our connections in different health authorities out as much as possible so that we're engaging people from all over the province. But again, it's one of those stories. What have we done? And we're doing some things well. What do we need to do? We've got lots of work still left. So tell them about the midwife. I don't know exactly the story that you're talking about.
Okay, Lana did all the interviews with the clinicians. And what she's not remembering in this moment of tension is that one of the interviews was profoundly with someone who is a midwife in a rural coastal community, and explained how her community and her response to that community is tied, of course, to their geography, social and political location. And so it comes up, and it happens that we chose that person's interview as one of the people to be interviewed, one of the cases that's included in the first season, but not the what's in the hospital, but rather the broader perspective. And that was so important because she was able to demonstrate that it is up to families to decide within the scope of what is available and so on, how they respond and engage with their circumstances. And she told some quite profound stories. I think it's important to just acknowledge, and though it was said, that our stories are embedded in our data. So we are inspired by those stories, and then we turn them into narratives and conversations between our hosts and then at least one clinician. So that's my first thought.
And one thing further I didn't introduce as to where our team is from. So I'm here, I'm based in the Lower Mainland, but Erin Bone, our other co-host, when we started the project, lived in Prince George, but she has since moved back to where she grew up, which is in rural, remote Manitoba. So Erin brings that lens to our team and brings us there as well. Rana. We can't hear you at the moment, Rana.
Thank you. I was just going to say, I think it's a very valid question. Projects can also start including some demographics around rural, remote, and urban to figure out what are some of those disparities. Our project was a little bit unique in the sense that while I would say probably the majority of healthcare issues would show disparities between remote, rural, and urban, that didn't come up in ours, and I think that is because there's just such a lack in specialized services for pregnancy loss currently across BC. However, of course, those who are experiencing losses in remote and rural communities have that particular challenge. You know, if they're having to drive an hour and a half to a hospital, those kind of things have a significant impact.
The only other quick thing that I wanted to add is because the product that we were working towards was a podcast, we needed to be informed by people who lived in a variety of different situations, but the delivery of what we were building got to defy all of those odds. And so one of the things that we heard about from bereaved parents is that in the middle of the night, when public health units aren't open and nobody's around, but they can't sleep because they're grieving, they wanted a podcast to listen to where they didn't have to travel anywhere and they didn't have to reach out to anybody. And so that really inspired a lot of the work that we were doing as we were we were really thinking about those people who were in rural and remote communities without any service and who were exceedingly lonely in their remoteness, not just geographically, but also within their grief. And that the podcast would defy those geographic boundaries to be able to connect and provide support.
So that's our official time slot. Is there a burning question for anyone? Please.
Can I just add, I'm a midwifery student, so this topic is like very near and dear to my heart. But I just have a request that you do a special episode about pregnancy loss during COVID, because I've heard some horror stories. And I think like it would be really, really helpful for someone to have a resource where they could hear stories about that experience during COVID.
There's some great, great research here in BC, excuse me, on the experiences of COVID. So we'll reach out and connect on that. It's my privilege to thank our speakers, to thank Heather for bringing us all together, to thank the organizers of this conference for the opportunity to share our work with you. We invite you to follow up with either team at your leisure, and thank you very much for your attention and time today, and wish you a safe journey home wherever that might be. Thank you.